deep emotion to welcome each one of you to the episode 6 of our Academic Myth Institute 2 series. Actually, you can't say this is episode, this is the 18th episode. We started at the time of Dr. Basavaraja as the president with the help of Dr. Yogesh, Dr. Upendra, Dr. Atanu, myself, and all EB member of the 24. Really, I want to thank you, of the total team of 24, including me, for this novel idea and novel episode. Every episode in this series has left us wiser and prouder. But today's session holds something very special, really. It's very special. It features the young, dynamic postgraduate students of Dr. Valandra Pawar Medical College presenting their research and academic work. And looking at this great success of this academic with institute, we have taken this idea that a PG academic, the lectures will be prepared by PG students, monitored by their lecturers, and that will be the set of 300 lectures will be on a digital platform for all postgraduate students. That's for those who are doing the MD Pediatric. So, thank you once again to old team, this new team, all these persons, those who are responsible and those who are instrumental in this series. To our beloved PGs, I want you to know that you are the heartbeat of our future. That's why we have developed that you are Pedicon. And we are giving more and more chances to you so that tomorrow you will be the more and more in academics in our conference. Your hard work, your curiosity, your courage to explore and question, it all matters. And today, the entire IP family is watching not to judge you, but to cheer you on, to learn from you, and to support your journey. Now, this journey is reverse. Usually, journey was initially from senior to junior, but nowadays we have done the reverse because we want to learn a lot from you. And I know you are that much capable that you are going to impact us how to learn, how to teach, and how to cope up. So, my request, go ahead with all these idea and not only to teach anybody but adapt yourself also. How to this along with academic, it is also very important that you have to go how to go the practice, how to be in good practice, and how to be a smart doctor. Maharashtra Academy also started that it's a smart pediatrician webinars also. You also attend that. That is also very important. This is more than just a presentation. This is your moment to shine, to lead, and to leave a mark. Really, first impression is the last impression. That's why whenever in future, this is your practice, but whenever you're going to have a lecture, be prepared and be smart for that. To the esteemed dean, Dr. Sudhir Bhambre sir, इनके बारे में क्या बोला जाए? Whenever we say, sir, Valandra Pawar Medical College में कोई activity करना, he is always ready, and that's a great thing about the Dr. Sudhir Bhambre and administrator of the Valandra Medical College, that our platform is ready. हक का platform होता है ना, वैसे type का. Along with the leadership of Dr. Ravindra Sonone, हम उनको रवि आबा बोलते हैं. And with his team, Dr. Deepa Joshi, Dr. Rahul Kopakar, Dr. Nilima Kadam, and others, so many, that list of the all the company taken by Dr. Yogesh. You are really gem. You are the asset for our IIP in academics. Your efforts in shaping the next generation of pediatricians is commendable. You are not just teaching medicine, you are building character, confidence, and compassion. मैं अगर कुछ बोलूं कि ज्यादा का नहीं होगा कि अगर सपोज in that area of Nashik, Mumbai, Pune, and everything, anybody want to go for a PG registration, the first choice is always Valandra Pawar Medical College. I really want to congratulate you for that, Ravi Abha and all the team. Really, that's a great thing that you have made in that department. My heartfelt thanks to my near and dear Secretary Dr. Yogesh Parekh, our dynamic Secretary General, for beautiful anchoring and supporting this vision. Special appreciation to Dr. Neelam Mohan, our President-elect, Dr. G.V. Basuraja, our immediate past president, our treasurer, Dr. Atanu, they are always really behind me in any project, anywhere, wherever I want. They never say no to any project. Really, thank you all. Thank you for your continued mentorship and guidance. And to Dr. Jagdish Chenappa, Dr. Priya Shivali, Dr. Amal Pawar, we can't think academic with institute without these people. Now Dr. Amal also added, and that's why we have decided that whenever there is a this academic institute, we will give chance to each executive board member and vice president to contribute in this. And my request to all my AB member, vice president, please be ready for that, and please help Dr. Priya Shivali, Dr. Jagdish Chinappa. You are the basic person with whom Dr. Priya and Dr. Jagdish can do the best. So really, thank you for ensuring the series maintains such high standard. And Priya, special thanks to you for continuing this series. At IIP, we believe in learning that is inclusive, collaborative, and deeply rooted in the real challenges of pediatric care. And that's why this series is so meaningful. It's not just about theory, it's about sharing lived experiences, clinical brilliance, and research that truly makes a difference. Before I close, I urge all IAPS, whether you are a senior consultant, a faculty member, or a young student, to be part of the journey. Watch this session, encourage your colleagues. Let's build a community that only cares but constantly learns. My special thanks to Dr. Avanti Paranspe, Dr. Vaidehi Chaudhary. They are going to do the magic today, because at IIP we believe academics is not a duty, it's a legacy. And together we will keep that legacy alive to prove our theme to serve children, colleague, and country. I wish happy learning. Thank you once again. Jai Hind, Jai Hind.
Thank you, sir. Thank you so much, sir, for encouraging words. Now I would request our President-elect, respected Neela Mohan ma'am, few words from you.
Thank you, Priya, respected Vasanji, President, and very hard-working Yogeshji, Atanu, respected Baswaraja, the chief guest for today, Dr. Sudhir Bangre, beloved Ramesh Bajania, who's the VP of the West, since it's a West Zone thing, and all the other VPs who have joined. I can see Prashant. Respected EBs, I can see few of them on my screen, like Lakshman Garu, Jalil, and seniors like Sumita Nayak, yeah, and the local team, whether it's Priya, whether it's Jagdish ji and Amol, who have been working in this direction. And I was just trying to pronounce this Valandra Pawar Medical College. And got to know that yes, VAR means esteemed. So this esteemed medical college is named after a political and a social leader who was a very good philanthropist, I'm told. And it was in 1990 that this institute was established. And the way it has grown, if it wasn't for the local team, that I wouldn't have known much, because Ravindra has been a bit close in his connections, and he ensured that all of us get to know about the glorified thing. And they have produced 3,500 UGs with nearly 500 PGs. So definitely they need to be showcased. And when I asked him once about the department, I was rather intrigued when he was saying that they have all specialties, whether pulmonology, cardiology, infections, etc. So I'm sure they have a lot to showcase in the beautiful city of Nashik. And all of us should not forget Na. Na is nose. So the ancient Shrupnaka story, which we've heard of in Lord Rama, Ramayana, is well known to us in that beautiful city, which not only has the ancient glory and culture, and also does the they do the what do you call every 12 years, that is done
Kumbh
Mela. Thank you so much.
Mela.
Melas, the ones. So I've also been lucky to see the temples. So I think it's a city which has not only documented that and has now moved to academics with colleges, engineering, medical colleges, enthusiastic, the conferences that they host, the NASICons, the dynamic women team that you find there who are there. So you have a lot to depict, and we are anxiously waiting to hear from not only Ravindra, who's the head, but also we have Deepa, Rahul, Neelima, who are going to showcase and talk about their department. And I think these academic institutions give us an opportunity to learn about our colleagues and to know how everybody is contributing to science. No doubt, India has reached a state where we are talking about development of super specialities. You are the ones who are taking from, from Tier 1 to Tier 2 to Tier 3, and absolutely Jai IIP and Jai Hind. I'm proud to be an Indian and proud to be on this podium today to see about this beautiful Ramayana city in Nashik from you all. Thank you once again for all the hard work that the local team is doing. My heartfelt, loving blessings and more power to you with a simple line that I have to say. For every goodness you do, you get back 10. But remember, for every negative thought and negativity you do, you have 10 times back that. Let us be good role models. We pediatricians who want to talk about goodness, like always Ramesh keeps telling to me that just think of positivity and niceness, and all the colleagues. I urge you all to look at the niceness and positivity, and let's put all the negativity out with Nashik reminding us of Ramayana, where goodness should win over evil who are trying to do damage to anyone, whether it's children or their colleagues. Let's get off all out of that. Thank you so much.
Thank you. Thank you so much, ma'am, for giving the historical overview about Nashik and uplifting the morale of all the pediatricians here. Thank you. Thank you so much, ma'am. I now request our immediate past president, Dr. G. Basavaraja, sir, for your thoughts on the...
You are muted, ma'am. Ma'am, you are muted.
Oh, sorry. Thank you so much, Neela ma'am, for all the encouraging words and bringing in the historical overview about Nashik and uplifting the morale of all the pediatricians here. Thank you so much. I now request our immediate past president, Dr. G. Basavaraja, sir, for your thoughts on Dr. Valandra Pawar Medical College.
Yeah, thank you very much, Dr. Priya. Respected our National President of Indian Academy of Pediatrics, Dr. Vasant ji, President-elect, Dr. Neelam ji, and our Secretary General, Professor Yogesh Parikh, Treasurer, Dr. Atano Badra, and all the seniors and OB members, EB members of the Indian Academy of Pediatrics. Academics through the institution is one of the most sought program. Even recently conducted executive board meeting, we have discussed how do we make the academics, which is really required for our pediatrician, teachers, and the postgraduate. So because all the three components are very, very important with the super specialty is setting in. Coming back to the Valandra Pawar Medical College, this is one of the, even though you can say it is a relatively a new medical college, the growth which has been occurred, I have witnessed myself, I visited the institution, academics which has been maintained by none other than Dr. Ravinder Sonavane and team. Really, it is a fantastic academic atmosphere, research atmosphere, and the patient's care, which is, I'm sure that today's deliberation, which is going to be discussed. It will be very, very useful to our pediatricians. Thanks to Ramesh Bajania, our Senior Vice President, who has been very, very instrumental in coordinating with our Amul Pawar, our Executive Board member from Maharashtra, and he happens to be from Nashik. And thanks to our core team led by Dr. Jagdish Chinnappa, and under his guidance, Dr. Priya Shivali, our national coordinator, who has been doing a great work. The best wishes for the today's program. Looking forward to having a wonderful academic mela which is going to be there. Historical things, Madam is already told. So looking forward for an academic things. Thank you very much.
Thank you, sir. I now request our National Advisor, Dr. Jagdish Chinnappa, sir, for your thoughts on the college.
Thank you very much, Priya. I think we are running short of time, so I am not going to take too much time. I'm just going to thank the Central IAP President Dr. Vasant Kaladkar, Dr. Yogesh Parekh, and all the other dignitaries. And I must congratulate the team from Nashik, and I must congratulate Dr. Priya for coordinating with Dr. Amul Pawar on this for this program. So I think I'm not going to spend too much time. I thank all of you for being here today, and let's take it forward.
Thank you, sir. I would now request our West Zone Vice President, Dr. Ramesh Bajania, sir, for your remarks and to introduce our respected chief guest, Dr. Sudhir Bambre, sir. Over to you.
Good afternoon, Priya. Good afternoon, everyone. Dr. Neelam ma'am, Dr. Basav sir, Dr. Vasant sir, Dr. Yogesh bhai, Dr. Atanu, and all friends. I must congratulate Dr. Jagdish Chinnappa sir, Dr. Priya, and Dr. Basavaraj specifically, sir, for last year for initiating this important program. And this is the only program which can be of tremendous help to not only PGs but to practicing pediatricians also. And we are privileged and proud that we have got a guest, Dr. Sudhir Bambre, who is a name to reckon with. He is a qualified surgeon, Dean and Professor of Surgery at Valandra Pawar Medical College Hospital and Research Center at Nashik. His main areas of interest are vaccinology. He is a UG teacher at MUHS, PG guide at MUHS, PhD guide at MUHS and Gujarat University. Surprisingly, examiner at various universities across India for MS MBBS examinations. He has got in his publications list 13 original articles, 1 case report, 1 international journal. He is a reviewer in MVP, Journal of Medical Sciences, Journal of Clinical and Diagnostic Research, ISSN. Research projects, he is a principal investigator for clinical trials, and NMC SSR for increase intake PG, NB SSR for dissertation, BCME faculty observer BCR, and so many affiliations and awards. It's very difficult to complete in a stipulated time. We welcome sir wholeheartedly, and I'm very sure that everyone will appreciate your presence in our prestigious program. Thank you so much for this opportunity. Over to you, Priya. Thank you.
Thank you, sir. I request our respected chief guest, Dr. Sudhir Bambre, sir, for your address.
Thank you everybody for giving me an opportunity to be a guest.
Please continue.
Yeah. Thank you for giving me an opportunity to be a guest on your very prestigious Academics with Institute program. And I really thank for IAP for giving our Department of Pediatrics of Dr. Valandra Pawar Medical College to give opportunity to show what are the things we do in our Department of Pediatrics. And for this, I actually thank the President of IAP, Dr. Kaladkar, and Dr. Neelam Mohan, the President-elect, and then the past President, Dr. G.V. Baswaraja, Dr. Yogesh Parekh, Secretary, the Atanu Badra, Treasurer of IAP, and the Dr. Ramesh, Dr. Jagdish Chinnappa, Priya Madam as a National Coordinator, and our own Amul Pawar as a Joint Coordinator for the station. And last but not the least, our Dr. Ravindra Sonamne and his team of Department of Pediatrics for doing a great job. And I welcome all those who have joined for this program. I see the Dr. Sagar Sonar is also joined, and I will just share my few thoughts. And I would like to be very happy to introduce our institution to this August gathering. Uh, Dr. Valandra Pawar Medical College is actually the baby of our own Maratha Vidya Prasarak Samaj. Our Maratha Vidya Prasarak Samaj is started in 1914. It's more than 110 years old institution. It is actually a trust, but it is not a personal trust. It's a trust of as a cooperative. They have 10,000 members spread all over the district, and there are elections every 5 years, and the managing council is elected. And this was started in 1914 with like 5 students in a Udoji Maratha boarding, and now it has grown up to the 2 lakh students per year. They are learning here in this institution, and we have more than 500 units all over the district, including the preschool, pre-primary, primary school, secondary schools, and all professional colleges like medical, engineering, architecture colleges. And it's a cooperative and social cause-oriented institute. And these are our founder members. You can see they started in the era of uh, around 1914, means Shahu Maharaj era. Shahu Maharaj is funded initially to this institution, and now the institute has flourished to such an extent. Our vision is to make the competent medical professionals. That is the vision of the institute, by giving them the knowledge, skills, the attitude, the social responsibility, and environmental sensitivity. Our mission is to make the professional or confident medical educators or leaders in the medical education field. And this can be achieved by giving them the benchmark quality education, enhancing the research, and improving the services to the society. And we actually is NAC B++ grade college, and we run the MBBS course with the intake of 120 undergraduate students every year, and we have the 75 seats of post-graduation in all clinical specialties mainly. And recently we started our PhD courses also in our institute. Academics wise, the last year's results, I just wanted to show that like they are around 96, 97%, and around 42 distinctions in all together. Even PG results are very good, 97%. In the area of research, we have more than around 40 peer-reviewed publications by the students and the faculty last year. And our various projects are going on under the MUHS and the National DHR, Department of Health Research. There are 8 projects which are selected out of 44, and 5 short-term projects out of 6 in the MUHS, and 5 long-term projects are under review. And at present, there are we have started last year the 8 trials in our institute, and more than 400 students get the scholarships. Our medical education unit is active, and they run the student programs for the faculty development as well as the students development. Like resident as a teacher is our workshop, which is regularly conducted in our institute. Our institute is also taking the part in the various sports activities and the cultural activities. You can see the photographs. We celebrate all the Ganpati, Shivratri, and everything, Navratri, in our institute. At the same time, we have been having our own hospital, charitable hospital of 1,000 beds. It's our campus is spread over 54 acres, and it's a huge campus with the affordable price. We can say it's almost 30% of the cost which is there in the private sector. So we are a charitable hospital in the North Maharashtra. 1,000 beds is our capacity, and 16 modular routines we have. Advanced cath lab is there, and all the specialties we run. These are the few services we provide: the ICU, MICU, SICU, HDU, NICU, PICU, and the CT scan. We have the 1.5 Tesla CT scan, MRI, and digital X-rays, ECG, and everything is there. These are few photographs of the facilities. And we treat all the specialties like general medicine, general surgery, chest medicine, pediatrics, orthopedics, OB-GY, ophthalmology, ENT, dental, psychiatry, skin, all the facilities are there. Even we provide the super specialty treatment, like we have a joint replacement, knee as well as hip. We have a neurosurgery department, cardiology, cardiac surgery. We do bypass surgery, surgical oncology, medical oncology, then neurology. We are in recent future we are starting the transplant unit also. There regularly there are dialysis units. We have 12 machines of dialysis, and there is waiting, always waiting. Neurosurgery is there, polytrauma, even critical care medicine and gastrology. We cater for the common people with the Mahatma Jyotiba Phule Yojana is there, Prime Minister's Yojana is there, BPL with ESIC. We have an MOU with for the secondary as well as tertiary care with ESIC. We have the antiretroviral therapy unit, and we have the MDR TB ward, separate ward for the MDR TB patients. We do all the deliveries free of cost, as well as the pediatric vaccination is done free of cost to the general population. Our future ventures are the colleges trying to increase. We are going for an increase intake of UG seats. We are going to increase, like we have finished our last inspection for UG intake. We are going to increase 30 more seats to our institute. We are planning to increase in the PG seats and starting a super specialty MCH, I think from the next year onwards. Hospital has got the plan of starting a super specialty hospital, organ transplant unit, radiotherapy unit, private wing of the patients, because the insurance patients are worried they don't want to get admitted. So we are starting off a private wing also, and NABH. We are trying to start get our hospital NABH accredited. And recently we have received the best medical college with research centered award with the hands of our national minister of the Patel Madam, Anupriya Patel Madam, and they have given us the award. Thank you. Thank you so much.
Thank you. Thank you so much, sir. Pranams to you. And your presence means a lot to the department and to all of us here. Thank you so much for giving an overview of the Center of Learning, Healing and Hope. Thank you so much for your presence, sir. I now request our coordinator for this session, Executive Board Member from Maharashtra, Dr. Amol Pawar, to introduce our respected chairperson, Dr. Ravindra Sonavane, sir.
Yes. Thank you, Priya ma'am. First of all, welcome again to all the stalwarts of IAP, all the office bearers, Dr. Vasant Khaladkar sir, Dr. Neelam Mohan ma'am, Dr. Basavaraj sir, Dr. Ramesh Bajania sir, Yogesh Parekh sir, Atanu sir, and all the attendees, our chief guest, Dr. Sudhir Bhambre sir, Dr. Ravindra Sonane sir, Priya ma'am, you, and then Chinappa sir. Actually, to tell you this, this institute, this educational institute is the second largest institute in Maharashtra after Rayat Shikshan Sanstha. It has got more than 500 schools across Nashik district and nearby areas. So as already sir has told, this institute has been started in 1990. And now our dear friend, he doesn't need any introduction to all the attendees actually, but to complete the formalities, Dr. Ravindra Sonane sir has done his MD from GMC Nagpur. Then he's currently professor and HOD pediatric in the same institute. And he's also from 2023, his PG coordinator. His areas of interest are vaccinology. Currently, he is treasurer of Maha Academy of Pediatrics. He was president of Nashik IAP in 2021, where he has got, where the team Nashik received various awards at state level and 5 national awards at national level also. So he's known as a workshop man in this part of this thing, Maharashtra, and also the highest position he has held in IAP, Indian Academy of Pediatrics, is he was a chairman of workshop committee at National Pedicon, which was recently conducted in Hyderabad. Then he has got various positions. He has taken various positions in IIP Nashik. He was a chairman of Nashikon last year. Then also he was treasurer of Maha IIP Sports. He was web zone coordinator in vaccinology module in last year's action plan. Actually, he's a multi-dimensional personality, he's a all-rounder personality, and he's a friend of friends to many. So here, I welcome Dr. Ravindra Sonani sir for his comments. Yes.
Thank you, Amol. So, good afternoon, all. I welcome and deeply grateful to our National President, Dr. Vasant Khalatkar sir, President-elect Dr. Neelam Mohan Madam, immediate past President Dr. Basavaraja sir, CIP Secretary Dr. Yogesh Parekh sir, CIP Treasurer Dr. Atanu Bhadra sir, Chief Advisor Dr. Jagdish Chinnappa sir, the National Coordinator Dr. Priya Shivalli Madam, West Zone Vice President Dr. Ramesh Bajania sir. I welcome and Joint Admin Dr. Parmanand Andankal sir. Then our friend and this power, Dr. Amol Pawar, Joint Coordinator, Action Plan, and all official CIP bearers who have given us opportunity to share our work on this national platform. So let me share my screen. Is it visible?
Yes, sir. Please continue.
Yes.
So I will be giving departmental address. So our vision is cure children and inspire students are our true motivations. So Maratha Vidya Prasarak Samaj, Dr. Valandra Pawar Medical College Hospital and Research Center, recognized by Ministry of Health and Family Welfare, NMC, and Government of India, and affiliated by MHS Nashik, accredited by NAC with B+ grade. So our home Nashik and institute, the sacred roots are in the Nashik, the holy city, on the banks of Godavari River, home to Trambakeshwar Temple, Saptashungi Temple, Vani, Kalaram Mandir, Shirdiwale Sai Baba, then also HL, where Sukhoi airplanes are made, currency note press, then artillery centers, and Grape City and Vinayas, and especially Kumbh Mela, which will be held in 2026. So this our institute's legacy was established in 1990 by Maratha Vidya Prasarak Samaj, a premier education hub, 1,000-bedded tertiary hospital, renovated recently with 5 modern OPD complexes. Our main inspiration is Advocate Nitin Baburao Thakre, who is Honorable Sarchitnis of MVP Samaj, Nashik. Now, this pediatric department is heart of our work. 2 professors, 3 associate professors, 5 assistant professors, 3 senior residents, and 9 residents. So this is the heart, main core, GABA म्हणतो आपण. So daily OPD, the count of 100 to 120 patients. We are having 5 cubicles OPD. All vaccines are given according to National Immunization Schedule and IIP schedule. NIS schedules are given free of cost. IIP schedule vaccines are given at subsidized cost. We are having ILR. So this was the photo of with patient of MR campaign, and our resident is giving vaccination to the patient. Now, pediatric specialty OPD, we are running on a specific days every week. So which constitute pediatric pulmonology, which is run by myself. which is equipped with peak flow meter, then portable pulmonary PFT machine, then spirometry, then pediatric cardiology, constitute of services like 2D echo with color Doppler, ECGs, even cardiac surgeries are done. Pediatric nephrology includes dialysis in the form of peritoneal dialysis, hemodialysis, and plasmapheresis. Pediatric endocrinology department is actually conducted by a pediatric endocrinologist, Dr. Tushar Godbole. We are treating many patients of short stature. We are giving somatotrop analogs through MPGY and many emergencies in endocrine, including diabetic ketoacidosis we are treating. And these are the other list of specialty OPDs like a pediatric infectious disease, rheumatology. Then pediatric neurology services includes ECG, EEG, then CT scan, MRI, NCV, EMG, then other specialty OPDs, pediatric hematology, child guidance, and child counseling. So we are also getting assistance from the other specialties like a pediatric surgery, neurosurgery, then child psychiatry, and child psychology. So we are having this intelligence scale, mainly Kamath Binet scale, then JSEL development scale, then Indian scale for assessment of autism, and this Vanderbilt assessment for use for diagnosing ADHD. We are running child rehabilitation service under one roof in which occupational therapy, physiotherapy, speech therapy are given. Our speech therapists are Dr. Nikki Chowdhury and Dr. Krupa Anthony. Pediatric intensive care unit is 10-bedded, which is actually seen by the pediatric intensivist, Dr. Abhijit Sangre, Dr. Amol Murkude, Dr. Akshay Patil, and NICU is seen by neonatologist Dr. Rahul Kopikar, Dr. Nilima Kadam. NICU is 21-bedded, tertiary level, 3-level NICU, which is consist of inbound, outbound, and transit or KMC unit. This fully air-conditioned NICU and PICU equipped with Macric and GE ventilators, then Fisher-Paykel CPAP, then laminar airflows, COVID and Nelcor pulse oximeter, multiparas, defibrillators, syringe pump, then air sterilizers, and all other emergency equipments. Now, pediatric ward, 90-bedded, 3 units, bed charges, basic medicine, basic lab investigations are provided free of cost. We are doing OE, ROP, and BERA screening for high-risk newborn. We are also running the NTEP, National Tuberculosis Elimination Program under respiratory medicine with collaboration of pediatric department. This is CBNAT machine. We are having multi-drug resistant TB ward also. So we are a very active skill lab in which skill lab activities like NRP, then PALS, BLS, and procedure simulations like IV cannulation, intubation, chest tube insertions, intraosseous insertions are taught to the UG student and PG student. Second, save lives. Our NRP drills cut response time by 47%. So undergraduate teaching, education is not the feeling of pain, but the lighting of fire. So UG teaching lecture, mainly case-based scenarios, small group discussion, OPD rotation, case presentation, skill lab training, field work, community pediatrics, and the formative assessment is taken in the form of bedside teaching, role play evaluation, and summative assessment done by theory exams, practical exams, and OSCE. And postgraduate teaching, we are every year we are having 3 PG students. So we are taking basic science lectures, advanced topics. We are clinically rotating interdepartmental and intradepartmental. Then also having skill lab training, then thesis and publications. The PG students are also mentoring undergraduates. They are teaching undergraduates, and they are also participating in community through field visits, then diagnostic camps, school health camps, We are conducting annually undergraduate quiz and postgraduate quiz. The coordinator for which is Dr. Sagar Sonone. This is we are taking zonal rounds. The students from three institutes of Nashik, Dhule, Jalgaon, Ahilyanagar, and Pravra are participating. Then these are the community work, community impact beyond the hospital walls, field visits and village camp. Other departmental activities like a mentorship program to relieve the stress management, then parent-teacher meeting to see what the parents have concerns. Then we are shaping leaders who are innovative thinkers, and we, along with that, we are graduating these all students. So apart from academic, our extension and outreach activity, we are very active. For example, we have conducted mass HPV vaccination program with the help of NGO and Rotary Club. We are vaccinated 3,000 girls of MVP school at free cost. When we vaccinated those 3,000 girls, we did not just prevent cancer, we ignited hopes. Other various health days celebrated to create awareness in patients, caregivers, UG students, PG students, other faculty and community, like a World Obesity Day, World Hearing Day, Rare Disease Day, National Immunization Day, Complementary Feeding Day, ORS Day, Breastfeeding Day, Ocean Pakwada, then this National Girl Child, then World Autism Awareness. We are conducted last year with the collaboration of MAHAAP. It was for a workshop for mainly parents. Almost 100 parents participated in that, and virtually Dr. Samir Dalwai also solved the questions of the parents of autistic childs. So this was about the National CPR Day. We almost actually trained 250 UG students and nursing students and physiotherapy students. Then World Hepatitis Day, we kept the panel discussion. Then the other CMEs, this continuous medical education is going on. Medicine evolves daily. Our CME ensures no child receives outdated care. Vaccinology CAP, our chief purple book, our guru of immunization, Dr. Kasi sir, almost 150 delegates attended that vaccinology CME at our medical college. Palliative care CME by Dr. Armida Fernandez madam at our college. Then DAPPAL CME on infectious disease. I was a vice chairman and Deepa Joshi was scientific chairman. Adolescent National Conference, all 4 workshops were held at our medical college. 4 workshops. I was a workshop committee chairman, and Deepa and Dr. Rahul was a coordinator for the Maharashtra State Midterm CME with Nasikon Conference. Also, 700 delegates attended it, and 4 workshops are held at our college, and workshop committee chairman was Dr. Deepa Joshi. Mahapedicon 2022 workshop, 6 workshops where 6 out of 8 were held at our medical college. Almost 550 delegates attended it. I was workshop committee chairman. These are the some photos where I participated in various conferences and CME as a speaker, and I was also felicitated for organizing secretary and workshop committee chairman at Mahapedicon 22. And other social activities like in 2021, we form IAP COVID task force. We were the first district to form this COVID task force. I was the chairman, and at that time I was also IAP president. Our pediatric department participated in Peace March against social injustice. The incidents happen against the medical students in West Bengal. So we are also participating in Healthy Baby competition as a judge, and with collaboration with Red Cross. We are also, apart from academics and this, we are also seeing the holistic health of our teaching staff, then our clerical staff and the students. These are the examples of birthday celebrations of teacher, then clerk, even external examiners. Dr. Bora Madam and Dr. Mora Madam's birthday was celebrated. Dr. Vaidhi Chaudhary resident's birthday. Now, and also we are giving farewell to our faculty resident is Dr. Amul Shigne, is a resident just passed. And we are giving thanks to who are participating in Adolescent for successful workshops. Then role play, MOC, judge, so various roles. And also in extracurricular activities, we are participating actively. We have just won MVP, won champion trophy in cricket at SMBT 2025. I was captain for that. We are also planting tree plant. We are taking some lectures on finance management also, and singing also. So this is our hospital growth and future. Our from Riverside Hospital to hosting national conferences, to as receiving accreditation B+ excellence and 1,000 beds and reaching village, and this continuing journey. And so future plan is to increase the PG seats and also to start DM neonatology in the future. Every child comes with the message that God is not a discourage of man. So Rabindranath Tagore, the poet, author, he told this. And we are just getting started. This is just beginning. So thank you, CIP, the National President Dr. Vasant Kalatkar sir, and all CIP office bearer for providing opportunity on this national platform. Thank you very much.
Thank you so much, sir. Request you to continue with the next keynote address.
Yes. So now I welcome Dr. Rahul Kopikar. He is associate professor and neonatologist for a keynote address. He will be mainly talking on high frequency ventilation. He has a vast experience in that field. So I welcome Dr. Rahul Kopikar.
Good afternoon, everybody. Respected seniors, dignitaries, faculty members here at the Medical College, all the organizers of this wonderful program. I'm extremely grateful for having this opportunity to deliver the keynote address in today's program. I'd like to talk about our experience with high frequency ventilation in our neonatal ICU. I'd like to divide this talk into three parts. I'll begin by going through a few brief cases where we'll be showing examples of how we use high frequency ventilation. Then we'll have a nice overview about how HFOV works. And in the end, we'll share some personal experience about how we have handled HFOV at our center. So the first case is a 28-weeker, 1 kg baby born with respiratory distress at birth. This baby was intubated in the delivery room, was given the first dose of surfactant. However, the respiratory distress persisted, ventilatory settings required were quite high. Blood gas showed significant respiratory acidosis and hypoxemia despite giving high FiO2. The X-ray, despite 1 dose of surfactant, still showed significant bilateral reticulogranular pattern suggestive of RDS. A second dose of surfactant was planned, but because we required such high ventilatory settings, we switched this child over to high frequency ventilation with the settings displayed on the screen. Over the next 24 to 48 hours, the work of breathing gradually settled, blood gas normalized, and by 48 hours of life, we were able to shift this child back to conventional ventilation. And by day 4 of life, we were successfully able to extubate this child to CPAP without any significant air leaks or lung injury. This is a second example of a 39-week term baby with a birth weight of 3.2 kg. This baby was born through meconium-stained liquor at an outside hospital. The baby was only shifted to us at 12 hours of life. This baby was quite bad at presentation, severe tachycardia, tachypnea, and respiratory distress. This baby had to be intubated as soon as it reached us, and we had to start on conventional ventilation. We started with moderately high settings as it is, and the X-ray was showing bilateral heterogeneous infiltrates suggestive of meconium aspiration syndrome. But the ventilatory requirements and the FiO2 requirements went on increasing, and at 18 hours of life, we had to shift this child to high-frequency ventilation. By around 30 hours of life, the work of breathing improved, but the FiO2 requirement was still quite significant at 50%. And by 48 hours, the blood gas improved. And by day 3, we were able to wean this child onto conventional ventilation, and we extubated him by day 5 onto CPAP. Again, no air leaks, no pneumothorax. The third case is a little more interesting. This is a 30-week male baby born at 1.1 kg birth weight. Again, had RDS at birth, received surfactant. This baby, despite giving surfactant, continued to have very high ventilatory requirements. And when we did the X-ray was surprising. We had bilateral hyper-expanded lung fields with many cystic lucent shadows in both lungs, suggestive of pulmonary interstitial emphysema. So this is usually a condition where over-distended alveoli tend to give rise to small air leaks between the alveoli and interstitium. And at this point, we decided to shift this child also onto high-frequency ventilation. This child took a long time to recruit the lungs, but gradually over the next 24 hours, work of breathing settled, and the X-ray at 48 hours of life showed resolution of the air leak without any pneumothorax, and we could wean this child back onto conventional ventilation by day 4. I think for want of time, I'll skip the fourth case. What we're trying to highlight with these 3 cases is that if we institute high-frequency ventilation early, we are in a position to shorten the time that we are stuck with bad babies on invasive ventilation. They hasten the process of probably normalizing your blood gas, and the patient can be extubated a little faster, which is what I think modern neonatology is all about. We try to be as non-invasive as possible. Now, what is the basic physiology of high-frequency ventilation? This is not new. The technology is quite old. In fact, the early studies were in the 1970s, and by 1990s, you had decently functioning high-frequency ventilators available. So what is so special about high-frequency ventilation? The inspiration comes from a panting dog. So if we look at a dog that is panting, we know that the dog breathes at very high respiratory rates, but very shallow breaths. What does this mean? It means that the tidal volumes are so small that they're almost less than dead space, but the respiratory rates are supraphysiological. This is the principle that through biomedical engineering, we've been able to channelize in creating these high frequency ventilators. The gas exchange in high frequency ventilation is quite different. Because you have tiny columns of air moving at rapid rates, but very, very small volumes, the entire respiratory tract becomes an area where gas exchange becomes possible, and all these very interesting new mechanisms start to come into play. I'll just mention 1 or 2 for want of time. Pendolift, as is written on the bottom left, is basically a phenomenon where an underrated alveoli communicates with an over-aerated alveolus, and the exchange of gas also give rise to good gas exchange in areas that otherwise in conventional ventilation don't really have any exchange of CO2 and O2. Similarly, collateral ventilation, that is connection between adjacent alveoli, is also something that you see more commonly in HFOV. Cardiogenic mixing is another interesting one. Because such small columns of air are moving, the simple beating of the human heart is going to aid in gas exchange, because with every heartbeat, the small channels of air that are moving together tend to mix, and O2 and CO2 tend to equilibrate. So these are some of the interesting mechanisms that are there in high frequency that you don't see in conventional ventilation. The open lung concept, or the concept of open lung ventilation, this is familiar to all intensivists, neonatologists, or anybody who's using a ventilator often. So what it means is that when you're ventilating a child at lower pressures, during expiration, the alveoli will collapse and they will undergo atelectotrauma. So you want to give pressures higher than this rate so that you don't have atelectasis. If you go on increasing pressures, the alveoli will go on distending. surface area will increase and gas exchange should improve. But beyond a limit, the gas exchange does not improve, but over distension can give rise to problems such as volutrauma, barotrauma, and with hyperexpanded lungs, you can also have decreased venous return, compromising hemodynamics. So we want to be between the zone of atelectasis and the zone of over distension. This is the safe window. Because in high frequency ventilation, inspiration and expiration both are active processes, we can keep our patients in the safe window with a little more precision. So that is one more advantage of using high frequency ventilation. This is a photograph of a high frequency ventilator. I've picked this one because the oscillator membrane that you can see in the center is actually visible from the outside. The modern day ventilators, all these components are inbuilt. You cannot see anything outside. And the rest of the components, of course, are the same as conventional ventilators. I won't go into further details like high frequency jet ventilation and flow interrupters, but essentially all of these provide short bursts of air at high rates with very small volume. What is the advantage? Why are we talking about high frequency ventilation today? So I think as clinicians, we are only interested in that right-hand side column, which says the key outcomes. So what are the outcomes that change? So in severe RDS, it is supposed to lead to lower rates of BPD. In MAS, it is supposed to cause fewer air leaks. When air leaks are already established, they resolve faster. And in PPHN, oxygenation improves better. In congenital pneumonias, improved survival is reported, although in very small trials. So these are all reasons why we should at least give high frequency ventilation a good go in our units. Anytime you have advanced modalities like this, you must have basic protocols in your institute. So the initial settings are what we end up training residents very often is, we have to set a map that is 2 to 3 above what we already have on a conventional ventilator. We set delta P or amplitude to get just enough wiggle up to the umbilicus. The frequency is set at 10 to 12, I ratio at 1:1 or 1:2. We don't touch these usually. Unlike in conventional ventilation, we don't touch the rate. We don't touch the I ratio. That is usually kept the same. And we adjust FiO2 based on the saturation of the chair. Most important part, that is true of any ventilation, but even in high frequency, is monitoring. If you look at the photograph here, the smallest thing in this entire photo is the baby. The monitor is large, the infusion pumps are large, the monitoring charts that you can see in the background, all of these are very large. So the first thing we tell our residents is, yes, monitor all this, but don't forget to look at the baby, because the baby's color, the baby's sensorium, the wiggle of the abdomen when your HFOV is running, all these are also very important parameters to monitor. Of course, we need blood gas, we need chest X-ray. Looking at these findings, you're going to adjust the HFOV settings based on the baby's condition. Anytime you have an emergency with a patient who is on HFOV, having a big manual of troubleshooting is of no use, because at 2 a.m. in the night, the sister or the resident is going to be the first responder. They don't want to open a book and look for what to do. So a simple chart placed anywhere near your ventilator will help. So the basics of troubleshooting are, if your PaO2 is low, that is the patient is under oxygenated, increase the FiO2 in the short term, but increase your mean airway pressure. So increase MAP. If you are over oxygenating, of course, you reduce the FiO2. If your CO2 is high, that means you are under ventilating this patient, increase the amplitude or delta P. And if your CO2 is low, that is you are over ventilating, that means there is CO2 washout, please decrease the amplitude. Although I've written frequency, these are not things that we will touch usually in high frequency much without consultants getting involved. So this is a basic troubleshooting chart that all residents, every first responder in monitoring an HFOV patient should know. When should we not use HFOV? So patients who have very high airway resistance, so patients with severe BPD, small micropremies as we call them, who have very tiny ET tubes like size 2, very difficult to send those high frequency jets through the small ET. So we avoid HFOV there. Patients with severe shock, very difficult to give HFOV because you need high MAPs to recruit the lungs, and that will reduce venous return and worsen shock. Patients with severe intracranial hypertension. Now, whenever you have such oscillatory ventilations, the fluctuations in mean airway pressures can compromise cerebral circulation. So anyone with an IC bleed, an intraventricular hemorrhage, known intraventricular hemorrhage in preterms, HFOV might not be the best choice. What is the evidence? Now, although I've very confidently written decreased mortality and early extubation, we must take this evidence with a pinch of salt, because this is evidence accrued over a few decades. Neonatology today versus neonatology 30 years ago is massively different. Today, we are all about non-invasive ventilation, caffeine, antenatal steroids. Back in the day, we didn't have all that. Almost every sick child would get ventilated. So there's a huge difference, and these trials tend to get pooled together to give evidence for HFOV. So yes, there are a lot of results shown in these studies, but we have to take them in the right perspective. What is our experience? So we have an SLE 5000 ventilator, which we use with an HFOV mode. The advantage we find in this is, just like a lot of modern day ventilators, we don't have to have a separate circuit for HFOV. The same corrugated tube can deliver HFOV perfectly fine. We were skeptical when we had this in the beginning, but yes, it does deliver wiggle very well, even though it's a corrugated tube. And the ease of use with the screen and display make it an attractive choice. We use HFOV primarily as rescue ventilation in conditions like RDS, MAS, just like the first few cases that we described. Our experience for elective use, that is first line use, that means we start ventilating with HFOV. We don't have a lot of experience. We've done it for a few preterms who have been referred from outside settings because they've already been on conventional ventilation, but not directly for our inborn babies. What are our difficulties? Whenever we have a new ventilator, there is first a lot of reluctance on the part of stakeholders. So residents, nurses, we're very scared when we have a new machine. Gradually, when we start seeing a few results, there is acceptance. And then once it starts working, we feel every sick baby, let's shift to HFOV. So that's also a risk. We don't want to overuse high frequency ventilation. The availability of ventilator tubings and circuits, these are all logistic issues. We have some issues with flow sensor because every now and then the calibration is a big issue. So this is something that having additional flow sensors available is very important. We have to make sure that the baby does not de-recruit. So for most other conditions, we tell our residents that suction on time. Here we tell them the opposite. Suction judiciously. If there is no need for suctioning, please don't suction, because every time you disconnect the circuit, the baby is going to de-recruit. And of course, the need for sedation is higher when you have a 2.53 kg baby, which prolongs extubation sometimes. So these are some of our difficulties. How should we prevent technical problems? If you have a good comprehensive AMC, CMC, fixing problems are important on time because you don't know when it's going to not work. Good inventory management, pragmatic sterilization or disinfection practices. Most Indian NICUs will reuse ventilator tubings. They are going to use ETO. So good practices are very, very important. And whenever you're going to think of purchasing a new ventilator with high frequency, take a long trial. The manufacturer will give you a long trial. You're not going to use high frequency every day. So get good enough experience in the trial period before you commit to taking a new ventilator. And last, but probably the most important, adequate training of residents and nursing staff is the key. To summarize, high frequency is quite an excellent tool for escalating respiratory support while minimizing lung injury. There are results like reduction in mortality, lower BPD rates, and improvement in oxygenation. But we must understand the physiology, have simple and clear protocols, train our staff regularly, and have good technical backup. This will make HFOV use much more feasible in our Indian NICUs with all its challenges. Thank you. Stop it.
Thank you, Dr. Rahul Kopikar. Madam, Priya ma'am.
Nice, sir. Please continue. We will have the discussion in the last.
Thank you, Dr. Rahul Kopikar, for igniting the knowledge of high frequency ventilation with the clinical practical experience and scientific evidence. Thank you very much. I am summarizing 2-3 words. So HFO works at the principle is supraphysiological respiratory rate using lower tidal volumes and HFO is working in safe window. So in between this atelectasis and over distension. So it is causing less side effects. So in severe RDS, PPHN, meconium aspiration syndrome, congenital pneumonia, and ear leak, definitely HFO, we have an advantage over the conventional ventilation. So now, being a short of time, now I invite Dr. Deepa Joshi for research presentation of the Pediatric Department, Dr. Valandra Pawar Medical College, Hospital and Research Center. I welcome Dr. Deepa Joshi.
Good afternoon, all. Thank you so much, HOD sir, and all the stalwarts of IIP giving this opportunity. myself, Dr. Deepa Joshi, Associate Professor from Department of Pediatrics. I will be presenting research aspect of our department and our institution. So research is nothing but what no one else can see or no one else can thought about it, but we have to think and we have to act on it. That is the research. So Dr. Valandra Pawar Medical College, Hospital and Research Center Institute has created an ecosystem, innovation, research and training to promote the research activities. Now this is our central research laboratory, and this laboratory has all advanced technological infrastructure to support the various research activities at national and international level like Avishkar, MUHS, ICMR, short-term research grant and long-term research grant. This is the facility which is used by preclinical, paraclinical and all the clinical departments for undergraduate, postgraduate students and as well as faculties. This is the CRL which is equipped with all advanced technology, and we have a simulators, various mannequins, simulation lab where we conduct various programs like NRP, basic life support, ALS, BLS, and this all help for the research activities. Now, the last year in a short-term student research grant, Director of Health Research, STS, where the 8 articles or 8 research topics were selected, and proud to say that 2 were from our department. Our faculties, HOD Dr. Ravindra Sonone sir and Professor Dr. Sagar Sonone sir, both articles or both research topics got the grant of around 60,000 per topic. And one topic was related to HPV vaccination in 9 to 14-year age girls, the parental awareness. And the second topic was related to HPV vaccine only, but it was related to awareness by medical or paramedical students. So we are really proud that our 2 topics got selected last year. Similarly, the MUHS long-term research grant last year was for the 3 from our institute, and short-term research grant were from our institute. 5 total topics were selected. Last year, we had 8 clinical trials, and now this year, we have 2 departmental clinical trials. One clinical trial is related to immunogenicity and safety of MR vaccine, measles rubella vaccine of 2 different companies. And the second clinical trial is related to 12-week study to evaluate the safety and tolerability of fixed dose combination of intranasal steroid of 2 different companies in an age group of 6 to 11 years in a patient of allergic rhinitis. Now, to do these all research activities, the tremendous material in the form of books and journals are required. So our central library is an excellent library where we have over 18,000 books, numerous national and international journals. There are separate departmental libraries for each department where 100 to 200 books are provided. There is a clinical key e-database. This key has accessibility for all throughout the campus. Even the students and faculties can access, and more than 1,000 ebooks and journals are seen over here. There is a AutoLib library management software, and this is very user friendly, and this software has a huge data in it. Each student or faculty can be registered, and there is accessibility for all the journals through this. Now, the institute is conducting various research training programs like research methodology, intellectual property rights workshop, good clinical practices workshop, clinical trial day celebration, and synopsis writing also. So there are various photos of these workshops. Recently, we celebrated on 20th of May, International Clinical Trial Day. Photos of basic research methodology workshop. Synopsis writing workshop is our specialty, that being a PG coordinator, our HOD sir has included this program in a PG orientation program so that every new JR who has joined get oriented to synopsis writing and the thesis part. Then the good clinical practices workshop. This is intellectual property rights sensitization workshop. Now coming to departmental achievement and awards. Dr. Ravindra Sonone, Professor and Head of the Department of Pediatric, was a moderator with stalwart panelists like Dr. Srinivasan, Dr. Sahana, and Dr. Geeta at Pedicon 2025 at Hyderabad. The topic was how to write a paper in a publication, and there was an excellent moderation done by HOD sir. Recently, in our midterm CME conference Nashik, there was a topic publication prescription where the sir has guided more than 400 delegates and the postgraduate students and motivated the students for research writing. Now, proud to say, and it is a happy moment that all our hard efforts come true when we got the award as a best department in the research award recently. Our two faculties, Dr. Ravindra Sonone and Dr. Sagar Sonone, has been awarded as a Best Researcher Award and Excellence in Research. Not only the faculties, but our residents are excellent in research. We had a national conference last year, AdolesCon 2024, and last year, similarly, Maha-AP Midterm CAP, in which our resident has participated and they have presented a paper presentation and poster, in which our resident, Dr. Avanti Paranspe, has got the Best Paper Presentation Award and Dr. Vaidehi Saudari as a Best Poster Presentation Award. Now, the dissertation on thesis is important aspect of residency, and we motivate our PG students for doing the thesis. The topic allotment, the topics are decided through mutual discussion with the student, and this ensures the relevance and interest. There is an ethical committee approval so that this ensures the ethical research practices. The statistician guidance, the statistician is available for the research methodology guidance so that ensures the proper data analysis. There is always collaboration with the CRL so that maintains the research standard also. And the research focus is mainly community oriented. Our topics for the thesis are related to community. To give an example, there was one topic like B12 deficiency and infantile tremor syndrome. The clinical profile of a patients with PEM. So we always motivate the students to do the thesis by heart, and that itself helps for the research. Now, coming to the faculty publications, as HOD sir has already told, our neonatal ICU has a 21-bedded NICU with all the facilities. So many publications are related to neonatology. So coming to that, I am telling some interesting researches which has been done. One was a screening of newborn by pulse oximetry for critical congenital heart disease patients. So here the 125 newborns were enrolled, and we took upper limb and lower limb saturations in first 48 hours of life and then before discharge. So this was a very good study where this pulse oximetry study can detect the congenital heart disease so that it can be missed clinically sometimes because the murmur doesn't appear. But if we get the hypoxia on this pulse oximetry, this is good screening test, and by this the two babies we detected, and it was confirmed by 2D echo. There was another article as a case series of neonatal arrhythmias at multiple centers in North Maharashtra, which has been done by our pediatric cardiologist, Dr. Prashant Badane. The study was done on these 42 newborns where the arrhythmia pattern we studied, and in which the supraventricular tachycardia was found to be a common cause of arrhythmia. And we found that these babies having an association with congenital heart disease also. Another topic was evaluating a risk factor correlated with the LBW babies. So 16 mothers were studied, and we found there is a significant correlation between maternal nutrition.
Hello, good afternoon, ma'am. Sorry to interrupt.
Yes, ma'am.
Ma'am, sorry to interrupt. Request you to wrap up because we are short of time.
Yes, ma'am. Just 2 minutes, ma'am, last. So another article was related to study of correlation of cord blood bilirubin with neonatal hyperbilirubinemia. So cord blood bilirubin less than 3 milligram per deciliter without any RH and ABO incompatibility can safely be discharged, and parental assurance can be given. But if it is more than 3, we need to have a good follow-up in these babies. There were 2 more studies from INICU. One was related to KMC, knowledge of KMC related in case of a low birth weight babies mothers, and another was related to role of symbiotics in improvement of fluid tolerance and weight gain in case of a low birth weight babies in NICU. We found that along with the routine care, if the symbiotics is given, the primary outcome was in terms of good weight gain and early feed tolerance was achieved. Coming to cardiovascular system, the effectivity of functional echocardiography in PICU patient. This study was done in a critically ill patients of PICU, and we found that the 2D echo, if done in early 48 hours, it usually helps to find the ventricular dysfunction, IVC collapsibility index, and IVC distensibility index that helps in a fluid management, inotropic treatment, and especially management of a critically ill dengue patient. Another study was impact of prenatal diagnosis on management and prognosis of infant with congenital heart disease. Here we divided the babies into two groups, the echocardiography done and echocardiography not done antenatally. Those who have been having a prenatal echoes done, definitely they have a less inotropic requirement, less ventilation requirement, and death rate was also less in these patients. Now coming to infectious diseases, we have lots many articles, but two I am just representing. Assessment of UTI in case of a febrile patient in a less than 5 years of age. Key message was all culture positive patients need to do ultrasonography because hydronephrosis, hydroureter can be missed. And another study was study of a serum electrolyte and calcium changes in a children with severe pneumonia. Here the hyponatremia at admission has a worst outcome. Then the other publications in which one was related to child obesity, other was related to the orofacial features in a victim of a child abuse and neglect. This was a very interesting study which was done in a 5 to 16-year-old child, and the child abused children have dental caries, aphthous ulcers, halitosis, and they lead to nutritional deficiencies. If we correct this, these children can get better nutrition. There was another study related to severe anemia also. Coming to the last two articles, they were very interesting. Study of eosinophil count in a nasal and blood smear in allergic respiratory diseases like asthma and allergic rhinitis. Now here the key message is that rather than pricking a child and doing a peripheral blood smear, the nasal smear is also good enough and giving a reliable eosinophil count, and this can be used as an alternative to peripheral smear in a patient of allergic rhinitis and asthma. And the role of zinc supplementation on a growth of low birth weight babies, we found that zinc supplementation 2 mg per kg per day for 8 weeks definitely help in a good weight gain in a low birth weight babies. So these are all the publications just showing whatever the publications in a journal we have done. Thank you. Thank you so much.
Thank you, Deepa, for research presentation. Research is the integral part of the innovation and science. Now I invite Dr. Vaidehi Chaudhary, our junior resident, for the case presentation, which will be moderated by Dr. Nilima Kadam. Dr. Nilima Kadam is assistant professor at our college. So I welcome Dr. Vaidehi Chaudhary for case presentation on HFI, hereditary fructose intolerance. Moderator is Dr. Deepa Joshi for the Vaidehi's case presentation. Dr. Deepa and Vaidehi.
Saving a choking child.
Good afternoon, everyone. I would now like to begin my case presentation. This is a case of an 11-month-old female, Afia Sheikh, who presented with the chief complaints of loose stool and vomiting since 15 days and abnormal body movements 1 day back. The baby was born of a third-degree consanguineous marriage, third by birth order of 3 children, presented with complaint of increasing frequency of loose stool and vomiting. These loose stools began gradually increasing to 8 to 10 times daily, exacerbated by feeds, and mild abdominal pain was present. The vomiting worsened with feeding. There was progressive yellowish discoloration of skin and sclera along with abdominal distension, which was gradual in onset and progressive. These symptoms began after 4 months of initiating complementary feeding and progressively worsened. The child had poor feeding, was lethargic and dull. There was 1 episode of convulsion, which was generalized clonic-tonic type, lasting for 1 minute, associated with drooling of saliva and uprolling of eyes. Baby also had increased respiratory rate and work of breathing, reduced urine output, and poor weight gain were observed. There was no history of fever. Past history and birth history not significant. Feeding history. The baby was initially breastfed. Complementary feeds were initiated at around 6 months of age, along with breastfeeding continued. complementary feeds consisted of rice, dal, nagli paste, boiled eggs, then added banana, roti mixed with dal. Parents noted that the symptoms appeared following the feeds. No cow's milk given. Immunization, immunized till 9 months of age according to national immunization schedule and developmentally appropriate to age. This pedigree chart denotes the family history. No siblings were affected. On examination, the child was lethargic, not interested in surroundings, and pale on appearance. Vitals suggestive of tachycardia, tachypnea, hypotension. Pulse was low volume and peripheral pulses were not well felt. Anthropometry suggestive of acute malnutrition. On general examination, icterus was present. Systemic examination per abdomen revealed a uniformly distended abdomen, and on palpation, hepatomegaly of 6 centimeter below the right costal margin in the mid-clavicular line with round edges, soft consistency, and non-tenderness was noted. A liver span of 12 centimeter was present. On respiratory system examination, there was nasal flaring, deep rapid respiration with intercostal, subcostal, and suprasternal retractions were present. Central nervous system examination was normal and cardiovascular system examination was normal too. These were the lab investigation done consisting of liver function tests, blood glucose levels, ABGs, serum lactate, and plasma amino acidogram. Course on stay. An 11-month-old female presented to the emergency department with complaints of loose stool, vomiting, and dehydration. Clinical examination revealed signs of severe respiratory distress and diminished peripheral pulses. Upon admission, the patient was intubated and kept nil by mouth. Initially, laboratory investigations were significant for deranged liver enzymes, hypoglycemia, ketone urea, elevated serum lactate, and high anion gap metabolic acidosis. Empirical treatment with intravenous antibiotics was initiated following blood culture collection, along with levetiracetam and sodium bicarbonate for metabolic correction. Following a period of stabilization, the patient was successfully extubated and feeds were commenced. Subsequently, the patient experienced a recurrence of symptomatology characterized by tachypnea, respiratory distress, vomiting, and documented hypoglycemia, again with evidence of high anion gap metabolic acidosis. This necessitated re-intubation, escalation of antibiotic therapy, cessation of feeds, and further administration of sodium bicarbonate until ABG parameters normalize. The patient was eventually weaned off ventilatory support as respiratory function improved and blood glucose levels stabilized, transitioning to oxygen via nasal prongs by remaining nil per oral. This consistent temporal association between feed initiation and development of acidosis, respiratory symptoms, hypoglycemia, lethargy strongly indicated an intrinsic metabolic derangement. Differential diagnosis considered included glycogen storage disease and mitochondrial disease. Diagnostic workup included serum lactate and plasma amino acid analysis. Notably, serum lactate was elevated. Plasma amino acidogram revealed significantly raised levels of fructose biphosphate. Definitive diagnosis was achieved via whole exome sequencing, which was suggestive of fructose 1,6-diphosphate deficiency, synonymous with hereditary fructose intolerance. The patient was subsequently counseled regarding strict avoidance of fructose-containing dietary component to mitigate the disease manifestations. Thank you.
Thank you, Vaidehi, for this presentation. I will just summarize in a 1 minute. So this child initially when came had a respiratory distress, had hypoglycemia. So we thought of this is all series because of sepsis only. But as the child come out and we started the feed, so feed induced whatever decompensation happened with this child, then along with hypoglycemia, that hepatomegaly, jaundice and everything, then this all took towards the some metabolic disorder, and we thought because of that. But now coming to this fructose intolerance, hereditary fructose intolerance, this child will thriving well till the weaning. He was growing well. There was no cataract, no developmental delay, and along with this high fructose level, we decided to send the whole exome sequencing, and from where we go to the final diagnosis. Now, interesting thing is that we need to counsel such a parent regarding diet. So we need to avoid fructose, but along with the fructose, sucrose and sorbitol also need to be avoided. So what products or what food we have to avoid, that list we have to give to the parents. So like fruits and all fruit juices we need to avoid. Honey, table sugar, sorbitol or sugar-free gums or candies we need to avoid. Sweetened cereals we need to avoid. Then sweet potato also need to get avoid. So all these things we counsel the parent regarding that. So thank you.
So thank you, Vaidhi and Deepa. Now I invite Dr. Avanti Paranjape for second case presentation with moderator Dr. Nihima Kadam, Assistant Professor. Avanti, welcome.
Thank you, sir. Good afternoon,
Please
everyone.
start. Yeah.
I begin with my case. There was an 8-year-old male who was born of non-consanguineous marriage, brought to us with complaints of fever since 8 days. The fever was acute onset, high grade, and multiple spikes a day. Child also had abdominal pain since last 5 days, which was epigastric and periumbilical. The child also had yellowish discoloration of skin and eyes noticed since past 2 days. And he also had difficulty in breathing since the past 2 days, which was acute onset, progressive, not relieved with any position changes. The breathing difficulty was associated with mild right-sided chest pain. There was no history suggestive of any hepatic encephalopathy. There was no history suggestive of any autoimmune etiology. Child had no history of recent or frequent blood transfusions. There was no history of weight loss. There was no history of any travel to any outside places. And there was also no history of any COX contact. On examination, the child had subcostal and intercostal retractions and tachypnea and tachycardia, hence was kept on O2 support by NRM. Child also had severe pallor and icterus. On per abdomen examination, the child had severe hepatomegaly, which was 3 centimeters below the right costal margin with a liver span of 11 centimeters. The liver surface was regular, soft consistency and round edges and non-tender. Child had splenomegaly of 5 centimeters below the left costal margin. There was no free fluid in the abdomen. Respiratory system examination revealed air entry which was reduced on the right upper lobe with crepitations heard on the right side. Other system examination was normal. So for a child with severe pallor, icterus and hepatosplenomegaly at 8 years of age, on investigating, we found that the child had severe anemia. HB was 2.3 with a WBC count of 62,000 and platelets of 1,40,000. PS revealed microcytic macrocytic picture with polymorphonuclear leukocytosis and elevated retic count. The child also had a positive direct Coombs test. His LFTs were also rearranged with indirect hyperbilirubinemia. ESR and CRP were raised, suggestive of autoimmune or inflammatory or infectious etiology. Other reports were normal, as mentioned. The CBC trends are shown here, which show falling hemoglobin even after multiple transfusions, which suggest ongoing hemolysis. The HRCT test was done for the ruling out any pulmonary pathology, which revealed infective or neoplastic etiology in the right lung. We did a bone marrow biopsy, which revealed normoblastic maturation and no evidence of hematological malignancy. Child was admitted to PICU, kept on O2 support. In view of severe anemia, we gave multiple PCV transfusions with the most compatible blood bag. Child had drop in hemoglobin even after the PCV transfusion without any clinical evidence of bleeding, which suggested ongoing hemolysis. Lymphoproliferative disorder was ruled out with bone marrow biopsy. Infectious etiology of the lung was suspected, and we started the child on IV azithromycin. Hemolysis was likely due to acute infectious etiology involving the right upper lung parenchyma. Considering the possibility of autoimmune hemolytic anemia, we gave a trial of IV methylprednisolone pulse therapy. Child responded well. The hemolysis responded to steroid therapy and oxygen support was gradually tapered and stopped. PCV transfusions were given until HB stabilized. LFT showed reducing trends and hemolysis resolved. There was clinical and hematological improvement, and the child was discharged successfully after 22 days of admission. Thank you. So this child presented with pneumonia, looking at deranged cell lines and hepatosplenomegaly, lymphoproliferative malignancy was suspected, which was ruled out by doing bone marrow examination. When we wanted to transfuse the child, getting cross-matched RBCs were very difficult. This was a previously healthy child with no past history of blood transfusion. Along with positive DCT reticulocytosis, we considered the possibility of autoimmune hemolytic anemia. So direct PUM test uses mixed sera, which cannot differentiate between warm antibody and cold antibodies. But if we make special request to the pathologist, we can always know about it. So other causes of autoimmune hemolytic anemias were also considered, like, so we did the ANA testing and all, which were all negative. So this was the case. Thank you.
So thank you, Avanti and Nilima. Over to Dr. Priya, madam.
Thank you. Thank you so much, sir. I think the postgraduates pulled it off. They have finished in 15 minutes. Wonderful presentations. If any questions are there, we can take up now. I think no questions. Request Dr. Jagdish Chinappa, sir.
Srinivasan,
This
sir.
is.
Thank you very much,
Oh,
team, for a wonderful presentation. And the cases were just excellent. Thank you so much. I'll just pass it on to Priya now. Thank you.
Thank you. Thank you so much, sir. Srinivasan, sir, any comments from your side? Thank you so much for joining in. We are having, your presence means a lot. In spite of you not being in India, you are making it sure to join. Thank you so much, sir. Sir, unmute, sir, unmute.
Presentations are excellent right from the beginning and this thing. Only thing I wanted to make this thing, the first postgraduate had cluttered this thing, informations in the slide. So, because nothing was visible, so I think that should be told. Because how to make slides and this thing. Of course, they wanted to, time was the this thing constraint. Probably they wanted to pack with a lot of information, but nothing was visible to this thing. So otherwise, everything was wonderful. I was enjoying it. Thank you so much.
Thank you, sir.
Thank you, Dr. Ravinder. We were there in the panel discussion in 62nd
He was
National
moderator
Conference.
to you.
Yeah.
Yes, sir. Thank you, sir.
Madam, can I ask one suggestion?
Yes, sir. Jalil, sir.
Wonderful case, and this fructose intolerance is a very rare case, and it is being confirmed by the accused. Is there any, like a lactose intolerance, is there any challenge test we can do for this fructose intolerance? Will it be useful? Fructose tolerance test.
Deepa, like, as in lactose intolerance, any challenge test to do for fructose intolerance? That's what sir is asking.
Okay, it is the like introduction of the feed only worsened the child. So that was the suspicion for this test. The fructose tolerance test nowadays we are not doing this.
Okay. Thank you so much. I think wonderful presentations from the whole department. I must thank Dr. Sudhir Bambre sir for giving an excellent overview of the institution, and Dr. Ravindra Sonavan is so emotional about the department. Thank you so much for wonderful activities going on in the department, and I think you have worked a lot to bring the department to this level today. And we all enjoyed the journey of a department from the beginning till now. And thanks to Dr. Rahul Kopikar, I think he made HFOE very easy, as it's not easy as such, so to monitor and things to take care of the babies on HFOE. I think Dr. Rahul, hats off to you. You made it very simple. And Dr. Deepa and Dr. Nilima, thanks for coordinating. I must congratulate the postgraduates, Dr. Avanti and Dr. Vaidehi. Wonderful presentations. Thank you so much. Backed by a wonderful faculty from the department. I think it was a worth session today. Thank you so much to the whole department. request Dr. Amol Pawar, our coordinator, who wanted this institute to be on the academics with institution very badly, as it was not happening the last episode. So he made sure it happens this time. So thanks to his commitment to have this institute on academics with institution. Over to you to deliver the vote of thanks.
Thank you, Dr. Priya. Actually, I just checked the group, and the group was formed in 2024 in the month of May or June for this institute.
Dr. Amol?
Yes.
I think network issue from his side.
He will join, madam. Yes.
Hello?
Actually, it's raining in Satana, so I got dislodged from my laptop. So, can you hear me, ma'am?
Yes. Please continue.
Yes. So it was very wonderful show from all the respected faculties from our Dr. Valandra Pawar Medical College, Nashik. As you have heard, Dr. Ravindra Sonone sir, our chief guest, Dr. Sudhir Bhamre sir, he has given whole history of how this institute has been formed. And to tell you, this institute, this institute is the same one where I studied from my first standard to 12th standard. So there was a emotional attachment for this institute. Even if I have studied in Pravara Medical College, Loni, but I have very great attachment to this institute, as majority of the faculties, they are very near dear friends. Dr. Sagar Sonone sir, Dr. Ravi Sonone sir, then Dr. Deepa ma'am, and everyone in other departments also. Many of the faculties are very near dear friends. So there was very good presentations, as you already told, by Dr. Rahul, Dr. Deepa ma'am, and both Vaidehi and Avanti. They presented the cases well, and Dr. Nilima ma'am and Dr. Deepa Joshi, and other faculties also, Dr. Abhijit Sangle, Dr. Prashant Badane, then Dr. Tushar Godbole, Amul Murkute, and various other faculties. They are working very hard for bringing this institute to the highest level. And already sir has told about the future plans of this institute. So hats off to sir and whole team of Maratha Vidya Prasarak Samaj Samstha Nashik. So also Dr. Priya ma'am, hats off to you. You are just amazing. Last year you conducted almost 52 workshops, and this year Vasant sir has cut down your this thing job, because almost 4 episodes were happening in a month. Now 1 per month. But I will request, there are lots of executive board members in Indian Academy of Pediatric in the tune of almost 70, more than 70. So I will request Dr. Vasant Khaladkar sir to restart this academic youth institution program every week, so that majority of the major premium institutes of all zones of Indian Academy of Pediatric, they will be covered till this thing. And I also request Dr. Neelam Mohan ma'am to continue this program in next year also. I thank all the attendees, all the IAP stalwarts, all IAP OBs, EBs, and all the members of Indian Academy of Pediatrics for joining and contributing. Dr. Srinivasan sir, Dr. Jalil Ahmed sir, thank you for your active participation in this program. So thank you one and all. Thank you.
Thank you, Dr. Amol. Pramod Jog sir was missing this episode as he's traveling. He couldn't join. He has sent his wishes to the institute. Thanks to the whole department once again. I would like to remind everyone the next episode will be on July 18th with another premier institution. Request all of you to join. Neelam ma'am, any concluding remarks from you?
Best wishes for that, but कहते हैं बहुत तरक्की की है और भी करना है. I was very impressed with your future vision. I mean, your vision and mission with which you are doing. There is lots to do, and I'm very happy that you people are reaching out to people where it is the need of the day, and continue. I was very impressed with the awards and all that, what research you are doing, because I think students teach us rather than we teach, because they make us learn more. So I always say, the other day also when you started the smart show, one of the thing I said that academics should be your pulse, your heart. I mean, whatever you're working, it's like it's an important organ of performance as a clinician. So that should continue, and it is so impressive to see that even there you all could do so much. More and more power to you. That's all I have to say.
Thank you, madam.
Thank you, ma'am.
And
You have
Amol,
made-
keep doing the good work, being humble, being nice, continue with the good work. Lots of wisdom and lots of luck to all of you from Nashik. Nashik rocks.
Thank you, ma'am.
Yes.
Thank you, madam.
Thank you. Thank you
Thank
so
you.
much.
Thank you, Devendra
Thanks
Sarin sir.
to
Thank you. Thank you,
Saji
Manaklal Chopra
and
sir.
to-
Thank you.
देवेंद्र जी नमस्कार.
Yes, sir.
आप हमेशा करते आज शिवाय आनंद
Namaskar, madam.
everybody
Namaskar.
I can see still Dr. Srinivasan is also there.
Yes, ma'am.
Regards to you, teacher of teachers.
Thank you,
Bless
madam.
you all.
Thank
Ma'am,
you.
our
so much
patron.
to all the EB members. Blessing you. Thank
Yeah.
you.
Thank you.
Our
Thank you.
patron,
you.
Dr.
Thank you,
Chopra
sir.
sir is also
Thank you,
there.
madam.
Chopra sir, Manaklal Chopra sir. Thank you, sir.
Thank you, Amol. Thank you. Thank you.
We
Priya.
enjoyed.
Thank you,
Thank you.
Srinivasan
Thank you,
sir.
Saji, and
Yes,
the
thank
whole
you,
technical
Srinivasan sir.
team
Thank you,
from
Saji.
IIT.
Thank you, Ravindra sir.
Thank you,
Amol.
Priya madam. Thank
Saji.
you.
Thank you so much, sir.
Thank you, Ravi sir. Thank you. Thank you. Thank you, everyone.
Have a
Dr.
great
Deepa,
day,
Dr.
great week,
Nilima,
and
Dr.
great
Rahul,
month. Okay. Bye.
Dr. Vaidehi, Dr. Avanti, and the chief guest, Dr. Bamre sir. Thank you. Sagar sir also.
Thank you.